Welcome to the International College of Surgeons United States session 60-minute webinar series. This is our ninth webinar, and our topic today is on duodenal derotation as a surgical management of SMA compression syndrome. I'm your host and executive producer, Dr. Robert Amajoy. Today, we welcome our speaker, Dr. Domingo Alvear. Dr. Domingo Alvear is a distinguished pediatric surgeon and founder of the World Surgical Foundation, who has devoted over 6 decades to advancing healthcare both locally and globally. Beginning his medical journey in the Philippines, Dr. Alvear was inspired by his uncle, a rural doctor, which sparked his lifelong commitment to medicine. His earlier career included a pivotal period at the Clark Air Force Base during the Vietnam War, where he performed thousands of surgeries. This experience solidified his path in the surgery, leading him to prestigious training in Philadelphia under the renowned pediatric surgeon, Dr. Everett Koop. In 1973, Dr. Alvear settled in Harrisburg, Pennsylvania, establishing himself as a pioneer in pediatric surgery. His leadership at Pinnacle Health, now pivotal in the neonatal care in that region, underscores his vision for children's health. Beyond his clinical practice, Dr. Alvear's passion for service culminated in the founding of WSF, World Surgical Foundation, in 1997. Through the WSF, he has led over 60 medical missions across 7 countries, performing life-changing surgeries for those in need. His dedication extends beyond surgery. He fosters sustainable healthcare improvements through training and equipment donations, leaving a lasting legacy in every community touched by his work. So Dr. Alvear's retirement from Pinnacle Health did not mark an end to his mission. He continued to lead WSF missions, ensuring that underserved populations receive critical surgical care. His impact transcends borders, embodying the belief that compassionate healthcare knows no boundaries. So Dr. Alvear's remarkable career also includes the development of the procedure that allows for effective treatment for superior mesenteric artery compression syndrome. We are very pleased that Dr. Alvear is with us today to share his technique and provide us with a new tool in the treatment of this challenging condition. Join me in welcoming Dr. Alvear to today's webinar. Dr. Alvear?
Thank you. The topic of this webinar is duodenal derotation with or without physiologic duodenojejunostomy is an effective treatment for superior mesenteric artery compression syndrome. I have nothing to disclose. During this presentation, we will discuss the history of the syndrome, etiology, pathophysiology, clinical presentation, treatment options, literature, and institutional review. In 1754, Bonner described the first cases of superior mesenteric artery compression syndrome, but it was Rokitansky who did autopsies in patients in 1861, and Laffer reported 217 cases in 1908. It became Wilkes disease from 1927 to 1960 and is still called by many patients even today. It became widely accepted disease entity in 1980 due to a CT scan, and in 2001, 3D CT angiography created a definitive diagnosis. Is there a congenital predisposition to the disease? Is linear growth at puberty without concomitant growth of girth is a factor? Excessive weight loss in short time can be a factor. Presence of spinal deformity or correction of the deformity can change the angle between the abdominal aorta and superior mesenteric artery, or prolonged immobilization in supine position, as in severe burns or body cast, or unknown. If you read the literature, there are now articles that support congenital predisposition of the syndrome. Short or thick ligaments can affect the angle and the distance between the abdominal aorta and the superior mesenteric artery. Pendulum effect of an elongated mesentery can affect the angle and distance between the aorta and superior mesenteric artery. An unusually low origin of the SMA can be a factor. Familial SMAS can also be seen. The loss of mesenteric fat or retroperitoneal fat as a cause for the disease needs more research. There's, there's current belief that if the patient regained his or her lost weight, the symptoms improve. This needs more research. According to the literature, this is an extremely rare syndrome occurring in 0.13 to 0.13% of population. What is well established is that majority of the patients are females and 80% are of asthenic build. The true incidence is not fully established. What happens when you have the syndrome? You'll have severe postprandial pain, early satiety, nausea, fullness, and eventually food fear. Vomiting is seen later. Delayed gastric emptying can be associated with disease, which can cause constipation due to absence of the gastrocolic reflex. Opioid dependence can also cause constipation and hypomotility. Biliary dyskinesia can then be seen. The cause of pain of the syndrome needs more research. Is it pulsatile compression of the SMA against the duodenum, causing transient local ischemia? Is it from the gastric distension or duodenal distension, or the to and from motion of the duodenal contents on the proximal duodenum? 80% of the patients are asthenic built, hence 20% are normal stature. Epigastric systolic trill or bruit are noted. Distended stomach can cause succussion splus. Syndromes that are associated with SMACS include median arcuate ligament syndrome. It's been known that they can be associated. Ehlers-Danlos syndrome and the posterior orthostatic tachycardia syndrome. Superior mesenteric artery compression syndrome is one of the abdominal compressions syndrome, which include median arcuate ligament syndrome, nutcracker syndrome, and May-Turner syndrome. In the nutcracker syndrome, the left renal vein can be compressed by the superior mesenteric artery, causing some venous congestion. If the syndrome is untreated, electrolyte imbalance and malnutrition can occur, which in turn reduces immunity to infectious disease and also to cancer. True mortality is not known. That is due to malnutrition and misdiagnosis. The definitive diagnosis of the syndrome is now with a 3D CT angiogram, or if allergic to dye, use the MRI. Gastric emptying study and HIDA study is also required, and Doppler ultrasound needed to rule out mouse. If contrast study of the stomach is done, it is best to do it when the symptoms are present. If the obstruction of the third portion of the duodenum is found or a filling defect is seen, the diagnosis is clear. delayed emptying of the proximal duodenum, and a to and fro motion of the contrast and some dilation will be diagnostic. 3D CT is now the gold standard for diagnosis, and MRI is used if one is allergic to dye. The angle between the abdominal aorta and the supramesenteric artery, that is 7 to 22 degrees, is abnormal. And the distance between the aorta and the supramesenteric artery, 2 to 8 millimeter, is abnormal. This is a 3D CTA showing the abnormal angle and a distended stomach. This is another study showing the narrowed angle between the two vessels. This study shows a markedly enlarged stomachs. This is an MRI demonstrating the obstruction of the third portion of the duodenum. Conservative management of the patient include frequent small feedings, minimal fluids between meals, use of pre-digested formula, and postural drainage. For severe cases, NG feedings is required. Total parenteral nutrition to supplement GI feedings is sometimes needed. You can live with the syndrome without surgical intervention. The surgical procedure will be described as we go along. Gastrojejunostomy should not be performed because it does not relieve the obstruction. Reflux can occur, blind lobe syndrome can occur, and anastomotic ulcerations can occur. Strong procedure releases the lignotrite without fixation. Problems with the strong procedure is that recurrence can occur because the DJ junction will return to its previous location, and there also could be a kink or twist at that area, hence recurrence of symptoms. The first duodenojejunostomy was described by Stavely in 1908, where there's anastomosis over the SMA. This is no longer performed. The bypass duodenojejunostomy was introduced in 1998. This is the most popular procedure and claimed to have 90% success rate. We still don't have a long-term follow-up to see how patients are really doing and as far as their quality of life and also the persistence of pain. Circular drainage procedure described in China does not solve the compression, and we don't have follow-up for this either. The problem with any bypass procedure is that duodenal compression persists, delayed gastric emptying can worsen, and diarrhea due to dumping can occur. Other procedures I will describe as we get along, which include the following. Anterior transposition was described by Duvi in Nigeria by dividing the duodenum at the site of compression and reanastomosis it anterior to the SMA. No follow-up for patients that was done. This was duplicated in Japan in 2007. Also, no follow-up is known. Dr. Darwin Anginokala performs a duodenostomy with staples. We still have to need follow-up for this procedure. Dr. Sandman in Germany introduced infrarenal transposition of the SMA. No long-term follow-up as yet. Other procedures are for the left kidney and also for cholecystectomy for biliary dyskinesia. Roux-en-Y procedure has also been done. One unpublished procedure is done by Dr. Wong in Singapore, is resection of the segment of duodenum at decompression followed by side-to-side duodenojejunostomy. So far, a patient that had this procedure 2 years ago is doing well. we need follow-up for this. We published an article in 1989 as a review and updated the article in 208, which included description of the procedure. From 1974 to 2016, we had 37 patients. Majority were females, age 4 to 21 years of age. They had abdominal pain, nausea, early satiety, and food fear. Not everyone had weight loss. One had a prior strong procedure, and one had a gastro, uh, prior duodenojejunostomy bypass. We performed this through a right upper quadrant incision, about 3 inches. The colon is mobilized to expose the duodenum and reflected outwards to expose the ligament of Trice. The principle of the Lodge procedure, the treatment of congenital malrotation is followed. Once the colon is mobilized and the adhesions of the terminal ileum from the right lower quadrant is performed, derotation can be accomplished, and you can reflect the entire small and large bowel to expose the ligament of Trice. The SMA is also seen. Derotation can be accomplished once the ligament of Trice is released. The objective is to have the DJ junction away from the SMA and will be on the right side. This shows that there's a kink at the DJ junction. Complete derotation show the small bowel on the right and the colon on the left. After release of the ligament of Trice and derotation, the DJ junctions must not be kinked or twisted, as shown here. Fixation is required at the DJ junction to prevent recurrence because a natural tendency is for the junction to return to its normal habitat. And the cecum has to be fixed to the splenic flexure to prevent volvulus. Appendectomy is done because the appendix is now displaced, so that if there's a future appendectomy, there's a future appendicitis, there will be any confusion. When there's a kink or twist at the DJ junction, a physiologic duodenojejunostomy is needed. Side to side anastomosis by hand or by stapling is needed. Here shows this posterior serosal sutures performed. Here shows the opening of the proximal and distal site, duodenum and jejunum. Here shows the inner sutures. Here shows the closure is completed of the serosa. This procedure will show you how to do a derotation. And the first thing is to release the colon away from the duodenum, like so, and follow that complete mobilization down to the ileum, because it's important the adhesions the normal adhesion in the terminal ileum have to be divided. And that's the only way you can do a total derotation. If you don't do this, it will not occur. And here you can see the duodenum at the second and third portion, and more adhesions are being released. And just make sure you don't divide any important blood vessels in this procedure. The cecum is on one hand, and more adhesions are released. At this juncture, you can just see the second and third portion of the duodenum. And that's the area where the ligament of Trice is. You have to pull it down. And the only way you can see this is you've done a derotation of the ileum. There you can see the third portion of duodenum in my finger. And you have to be careful and slowly release the attachment of the duodenum this on the third and fourth portion. The harmonic scalp is being used because it decreases blood loss, facilitates the dissection. Now you can see the third and fourth portion is being shown as we slowly find what the ligamenoarthritis is. And you can do this bluntly. And as you see more adhesions, you can divide it again with the harmonic scalpel. As we stay close to the at the DA junction, you can see a kink right at that level. So we try to release as much as we can so that that area should be straight down on the right side once it's completed. The duodenojejunostomy junction is now completely mobilized, but you can see there's quite a bit of kink at that area. So you can see that the jejunum is now most on the right side, but the junction between duodenum and jejunum is quite kink. You continue to try to mobilize that so that we don't have to do a duodenojejunostomy. So there are more adhesions that can be divided safely. Now you can see the dilated duodenum proximally compared to the undilated duodenum distally. The duodenojejunostomy junction is quite kink, as you can see there. So then we can perform what I consider a physiologic duodenojejunostomy. In our situation, we have to do an open technique, but if you have staples, you can basically just do a staple anastomosis at that level. You can see now the superior mesenteric artery away from the duodenojejunostomy junction. We then do serosal stitch as our first step when you open, and then you open the duodenum and jejunum anteriorly to do then the inner stitch between those two structures. After that, you close the opening with a serosal stitch using an absorbable suture first, followed by a second layer of non-absorbable suture like silk. At this juncture, we then insert a gastrojejunostomy tube, the opening made in the stomach, followed by feeding the tube into beyond the anastomosis and into the jejunum, and this will be used for feeding later. You must fix two areas. The first one is to fix the DJ anastomosis to the right abdominal wall, as you can see here. It's important because the natural tendency for the structure is to go back to where it came from. And the other is we remove the appendix generally we do what known as an inversion appendectomy, because then the appendix will be in the wrong place. So when the patient develops appendicitis in the future, there'll be no confusion as to the diagnosis, and the appendix has been removed. And the reason for the inversion appendectomy is because lessen the amount of contamination during surgery. So the operation continues to be clean case rather than potential contamination. The mesentery of the appendix has to be completely divided using the harmonic scalpel, and then forcing sutures placed around the base, and the appendix inverted with a probe. And then a tie is applied at the base once the appendix inverted totally into the cecum. And that completes the appendectomy, total inversion appendectomy. The appendix will devascularize and fall off in about 7 days. And this has been proven by a paper I wrote during my residency. And that completes the inversion appendectomy. The next step is to fix the cecum to the splenic flexure, and this will prevent volvulus. It's very important that this is done, because there have been some patients who had volvulus if the cecum is not fixed. This is done by simple suturing on the serosa, or using non-absorbable suture. And that's it, completed. End of the video. Our study shows that the small bowel is now on the right side, and there's no, and the duodenal junctions away for the SMA. This is the delayed film showing the colon is on the left side. Majority of the patients only required duodenal derotation with fixation. 6 patients required physiologic Duodenojejunostomy. 6 required antrotomy due to delayed gastric emptying, or are doing well, 10 to 14 years follow-up. Dr. Daniel Shawhead in St. John's Hospital in LA is now performing this procedure robotically. This shows the kink after robotic derotation. Physiologic Duodenojejunostomy using staples robotically. This shows the completed Duodenojejunostomy. What's needed in the superior mesenteric artery compression syndrome clinic is a team of surgeons, gastroenterologists or primary care physician, nutritionists, pain management specialists, psychologist or psychiatrist, social worker, and clergy. In conclusion, superior mesenteric artery compression syndrome is a true disease entity. Gold standard for diagnosis is a 3D CT. Conservative management attempted first before surgery is contemplated. Duodenal derotation with or without physiologic duodenojejunostomy with fixation at two sites has long-term excellent results. Antrotomy is needed when there is delayed gastric emptying. Always look for median arcuate ligament syndrome before performing superior mesenteric artery compression syndrome surgery. Patients can do well without surgery with frequent small meals and postural drainage when full. Team approach is needed. Research needed for the role of mesenteric fat as the cause for the disease. Research on the psychogenic aspect of the disease is needed. What is the true incidence? The timing for surgical intervention and the need for to find the surgical procedure that can cure.
That was an excellent presentation, and you've been very busy lately, traveling all over the world and teaching surgeons. Um, I don't know how you do it, but let's go ahead and jump in right into this Q&A session. And so, SMA was first described by von Rokitansky from Austria back in 1861, and as the obstruction of the third portion of the duodenum due to arterial mesenteric compression. How do you define SMA syndrome, Dr. Alvear?
SMA syndrome is a rare disorder that, as you mentioned, and it's where the superior mesenteric artery compresses against the third portion of the duodenum, causing an intermittent obstruction. It's not always present, and it's not complete. And then there are good days and bad days for the patient, and so it takes some time for people to discover that there's a problem. And so when there's a obstruction for quite some time, then the patients start to have a lot of pain. Then they have nausea and early satiety, and then they feel full, so they won't eat. Then they also have a food fear because every time they eat, then they have a lot of pain because I believe that after you eat, there's increased pulsations, so therefore there's a bounding pulse into the duodenum, hence the
Mhm.
food fear.
Is there like any genetic predisposition to this?
Yeah, I believe that there's some congenital predisposition because it's something to do with the ligament of Treitz being either very thick and high in origin, therefore causing a kink at the fourth portion of the duodenum, and causes the duodenum then to be at the angle between the SMA and the aorta, and that could be a congenital predisposition. And I believe that there are kids who are born with this, and there have been some reports in Russia and China where even it was diagnosed prenatally. And my youngest patient that I performed the procedure is 4 years of age.
4 years.
Four
Wow.
years of age.
And since we're talking about age here, was there a life expectancy for this if it's gone untreated?
Well, nobody knows for sure what the life expectancy or mortality of this condition because some people have died recently without treatment, and we don't know what caused the death other than malnutrition. Some of it is malnutrition probably, and some because depression. They become depressed because nobody knows what's going on with them.
Mm, wow. Um, so no, your background is obviously pediatric surgery. And do you think that every patient needs surgery for this? Because I know the initial treatment is conservative management, right? Um, what's your thoughts?
Um, you can have an SMA syndrome all your life if you can handle it with, if you can handle eating frequent small meals, and then you can do postural drainage where you either lay on your right side or your left side, depending which one relieves your pain, or you can do on a prone posture uh, after you eat, and actually assume a position like a puppy dog, and that will relieve your discomfort when that happens. So if you can learn how to eat properly uh, without drinking too much at the time of meal, maybe 6 times a day meal, and uh, and then maintain your weight. Or if your child, you can grow and you're not retarded in growth, etc. Then you can survive without a surgery. I have actually uh, a surgeon I know that has the SMA syndrome and doing well. He's very thin. He's asthenic built, but he said he's comfortable with it.
Wow. Okay. So interesting. So these patients obviously they come to you. So let's walk me through how you would, what sort of investigations you would do. This patient comes to your office, and you sit in your office and you look at it, it's 9 o'clock in the morning. The first patient is this patient who is, let's say, maybe 14 years old. Um, what's your first step, and how do you investigate to this particular problem?
Well, in the old days where I was trained, we only had the upper GI series, which is the using contrast material like barium. And when you do that, you make sure that you perform the procedure with a radiologist who's very patient in performing the procedure. Because if they do the routine upper GI, it goes right through, and they don't do fluoroscopy. They don't follow the barium from the stomach down to the duodenum, and so then it's negative. Obviously, it becomes negative because it goes through. It's not obstructed. But if you follow the contrast in the stomach, and you can see the duodenum has what we call a to and fro motion, and you might find a filling defect, or it cut off at the third portion of the duodenum. You can see a cutoff,
Mm,
but it has to be done uh, patiently, supine. You can do all kinds of positioning, and then you can see a delayed emptying of the barium or the contrast afterwards. So it has to be done appropriately, and has to be done when the patient is symptomatic.
okay.
And if your patient is asymptomatic, it's negative. But now we have CT angiography, which is really the gold standard for diagnosis, because you can then measure the angle between the SMA and the aorta, as well as the distance. And there are parameters that the radiologists follow now, the standard for that. And you can make a definitive diagnosis.
So what angle you're looking at on a very acute angle of the SMA in respect to
Yeah.
the aorta? What angle is that? What do you expect to see?
Well, you can make a drawing of an angle, and if it's below 22 degrees angle, you'll see, you're going to have a narrowing. If you
22.
have the distance between the SMA and the aorta is between 2 and 8 millimeter, when it should be 25, then you got a narrowing. So you can measure these things now, and then when you do a sagittal section, you can see the narrowing of the aorta and the SMA, and you can see compression in the duodenum.
Okay. So I don't know if there's a condition from rapid weight loss after gastric bypass. Patients can develop something like this. Is that similar, or is that something different?
Right. Those rapid weight loss from bypass is not. You don't see a commonly any SMA syndrome problem. because see, a lot of people in the literature, they think that gaining weight would improve the condition. That's why they give the nasojejunal feedings. Sometimes they give them TPN, in trying to say that there's a mesenteric fat that would allow the SMA to be away from the aorta. But nobody has really proven that for sure, because that by doing so they get better. That's why they bypass the so-called uh, duodenojejunal bypass procedure
Right.
for SMA. Helps for weight gain, but it doesn't help the pain because the compression persists. And that even if they gain weight, patients still are symptomatic.
So before I jump into the Alvear procedure, obviously, historically, you mentioned duodenojejunostomy, right? Can you describe that procedure, and then we're going to jump into how that contrasts with the Alvear procedure?
Well, the old duodenojejunostomy was very complicated. This was actually performed in 1908, and that's when they put the jejunum in front of the SMA,
Right.
and that's no longer done. So currently what's done now, either open or laparoscopy, is they put a jejunum, another loop with the jejunum more proximal towards the second portion of the duodenum, anastomose it there. And the idea is for them to relieve them of their inability to eat, and they do improve. And some people actually have good success with that. This was first introduced in 1997, the idea, and uh, follow up of patients. They do well afterwards. They gain weight. They feel they have sense of well being, and some of them accept their discomfort because they can maintain their weight and they can go on with their lives.
Mhm.
But some of them don't do very well. They are more miserable, and then you ended up with the closed loop syndrome, and then you still have reflux. You're gonna have reflux. Bile reflux will be a problem, and so some people um, don't do well. According to the literature, they say 90% success rate, but I'm not sure about that because we see in the website a lot of people complaining after the
Mhm.
bypass.
So I remember you. I was privileged to hang out with you at the ICS
Yeah.
this earlier this year, the conference. So I remember you talking about that the idea came to you back in the 1970s, and so what was the aha moment for you to where you said, "Hey, there got to be another way." Um, so walk us through how that came about.
Well, actually, my idea was no bypass from the very beginning, and that is just to simply. My idea was, what if you remove the third portion of the duodenum away from the SMA, and how do you do that? And so that's when the idea of derotation came into my mind. I just didn't know what to call it. I call it a derotation because and you actually create a malrotation you by doing so.
Yes.
And so knowing how to correct malrotation as an attending and a fellow before that, I said maybe that's the way to go, and that's what I did. So I've done a derotation in about 35 patients,
Okay.
and also I did seven what I call a physiologic duodenojejunostomy, where you anastomose the jejunum into the duodenum at the side of the kink. Because what happened after you do the derotation, some patients do well. You can just straighten out the junction, and you can fix it on the right abdominal wall, and they
Mm.
do well. No anastomosis. But some people have a twisting as well as a kink at that level, so you have to anastomose it so that there won't be an obstruction.
That's pretty high volume, 35 of these cases.
Yes.
And this is across the globe, essentially, correct?
Well, right now, because I'm involved in traveling, It's now 40. It's over 40 patients now.
Okay.
It'll be in next month. I'll have two more to help. So there'll be 42 patients.
Wow. Has there? I mean, I was watching the video as you were presenting. The interesting thing that you did there was that inversion appendectomy.
Yeah.
Um, what is the role of that?
Well, the reason for the inversion appendectomy was supposed to that if you do an inversion without cutting the appendix, then you lessen contamination. But I find that's not true anymore, because when we did one in South Africa, we just went ahead and did the staple it, or you can just tie it. In Virginia, we just did a staple. So
Right.
I don't think, if you can do it cleanly, I don't think you can do inversion, because it takes a little bit of time to do. If you don't do the inversion, it takes 5 minutes to do the inversion appendectomy if you know how to do it. But it takes a little bit of time. But if you can just do it the normal way, so long as you lessen contamination, then you have less, no problem.
Right.
It's
Because
not necessary.
in the world of stapling, exactly, I wouldn't think. Yeah, but that was interesting because I've never heard that even phrase before. Not alone. Yeah. So that's interesting, and so I guess this will be a modified obvious procedure now.
Yes, correct.
All right. So this is quite fascinating, and I wish we have a whole lot of time, but um, you did a very good job on that presentation. And uh, the question I have is how could surgeons that are watching this now, how could they reach you? I'm sure there's going to be a lot of people who will be interested in learning how to do this procedure. Is there a number, email address they can
Yes,
reach you with?
they can email me or text me, and there'll be an email address and a phone number. And in fact, I have an invitation maybe to go to Egypt
Oh, wow.
shortly, and then there would want England. There are two patients in England, and Ireland, Netherlands, um, Belgium.
Oh, my God. So what are the age groups here? I mean, this is a lot of
These are ages from teenagers, 13 to 17, to adults. The oldest one is 37. That's the
oh,
one from Egypt that had all kinds of crazy operation they did on her. And so I told them we'll be glad to reverse what you had and perform the Alvear procedure.
wow. Be sure to take me with you for that
I'd
adult
love
visit.
to. You would love to. Then you can learn. Not only can you can learn the procedure, actually, because you are a good surgeon, so anybody can perform this procedure without any complications.
Wow. Well, I think this concludes our session on this Q&A. And if you have any more questions, obviously, Dr. Domingo will. By the way, do you have those numbers that you want to give us, or email address if you want to say that on air?
Alvr15@comcast.net.
Okay, so you can see it on the screen there. Take a screenshot of that. And if you have any questions, if you want to learn this procedure, if you want Dr. Alvear to come to your country, he'll be glad to get the email from you and let's get this going. So this really concludes our session, and special thanks to our ICUS family. This was definitely an excellent webinar. Today we've learned that the Alvear procedure is an alternative procedure for um, the SMS syndrome, and um, I've learned a lot. Dr. Alvear is very busy. He's traveling all over the world teaching surgeons how to do this procedure. And if you have any questions, you can reach out to him. Um, so for our next webinar, take a look at our website. We'll see you soon. Again, I'm Dr. Robert Amajoy. I'm the executive producer. Thank you very much.